really excited to introduce Dr. Tahseen Mozaffar, who is a professor of neurology and the interim chair of neurology at the University of California at Irvine. He, as a lot of you are probably familiar with, is an expert in GNE myopathy and a member of NDF Scientific Advisory Board and a member of our Board of Trustees. So I will introduce Tahseen, but before we get started, Dr. Mozaffar, I just want to remind everyone to please keep their microphones muted and their cameras off so that we can focus on Dr. Mozaffar's presentation. Feel free to please enter questions as they arise in our chat box, and I will come on at the end of Dr. Mozaffar's presentation and I will get all of your questions answered. So with that, I will give it to you, Tahseen. Thank you for joining us today.
Okay. Let me just finish this and okay, perfect. Thank you, Nancy. This is a great pleasure. And what Lale and Nancy wanted me to do was to bring up this concept of multidisciplinary care clinic, specifically directed towards the care of GNE myopathy patients. And it's a model that some of you may be familiar with, especially in the US and in the UK. If you have attended one of these clinics that is sponsored by the Muscular Dystrophy Campaign or Muscular Dystrophy Association, and I'm sure there are similar models in other parts of Europe as well. But it's a concept that would apply very well to GNE myopathy patients and actually has major advantages. And what I like to do is to at least bring that up as part of this half-an-hour session that I would like to spend with you. So as Nancy mentioned, I've been at the University of California, Irvine for the last 20 years, and in the process have seen many patients with GNE myopathy and participated in most of the clinical trials with it. GNE myopathy is, it's an ultra rare disease. So even though I'm used to seeing rare and orphan diseases, GNE myopathy, even amongst them, is extremely rare. It's an autosomal recessive disease, so there are certain ethnic predilections for this disease. In the US, at least, it tends to be bi-coastal. So I can tell you, I did all my training in St. Louis, Missouri, which is in the middle of the US, and I had never seen a case of GNE till I came to California, and actually till I went back to Pakistan initially, where I saw my first family. And then when I came back to the US, it made me easier to recognize the cases of GNE myopathy. So if you look at the current situation in the US, most of the patients with GNE myopathy are distributed in a bi-coastal distribution along the either the eastern seaboard or along the Pacific coast. So there's a very large population, relative large population in Southern California, mainly around the Los Angeles region and greater Los Angeles region. There's a pocket in New York City, especially in Long Island and in Nassau County. And then there are similar pockets in Canada, in Toronto and in Vancouver. Typically, it's considered to be a Middle Eastern disease, mainly in the Persian Jewish as well as some of the Iraqi Jewish populations. But the more you look for it, the more you recognize that the disease is actually quite prevalent in other populations, especially South Asian population, India and Pakistan. And it originated with an original mutation that came from Iraqi Jewish migrants. But it's also present in the non-Jewish Persian population. It's also present in the Arabic population, especially from Kuwait and Saudi Arabia. And there are increasing number of cases being reported from the Chinese areas, so especially mainland China as well as Taiwan. There is a fair amount of variability in terms of disability. So even within families, some family members with the same mutation may be greatly affected. In other family members, the amount of disability may be much milder. So we really don't understand the factors that are responsible for the variability at this point. And this is an area of active research. And we would like to at least understand this better because it may impact treatment outcomes as well. The bigger problem are the unmet needs in GNE myopathy. At this point, we really don't have a very good and very long natural history data. So natural history is a term that we use for how the disease behaves over a period of time. So for instance, if somebody gets diagnosed with GNE right now, what is the likelihood that they will get disabled to the point of needing a wheelchair, etc., over the next 10 years? And that is the natural history of the disease. So the progression of the disease over a certain period can be quantified, and it can be measured. And that is an important piece of information to be able to plan clinical trials. So if I am planning a treatment trial where agent X, for instance, is the intervention that I want to do, I need to know how fast does the disease progress in any individual or any groups of individual, because my statistical calculation, all my planning is going to be based on that rate of progression on that. And right now, we unfortunately don't have this data in a reliable fashion. Ultragenyx had done a natural history study that was a very well-designed natural history study that was going well, but the moment the drug failed, they pulled the plug on it, so the natural history study was closed. We still don't have full access to the data from that study. There's a similar effort going on at the NIH, and we have some data available from that. Cases of respiratory involvement, respiratory failure in GNE myopathy, and that really needs to be looked at in more details. The disability assessment, especially the rate of progression to the point of using a wheelchair and other equipment, needs to be quantified better as well. Because it's a rare myopathy, and given the location of this disease, mainly in the bi-coastal region, most of the big academic centers, even in the US, really do not get much exposure to this disease. So trainees who are coming out of these programs have not seen this disease, and they may not recognize the disease in a ready fashion as well. So as I mentioned, there may be delays in diagnosis of GNE myopathy, especially if you're not looking at risk population. So obviously the fellows are trained well. So if we see a Persian Jewish patient, we think about it. But what if this is not a Persian Jewish patient? What if this is somebody from a Caucasian? And we've had patients who were Caucasian who had GNE myopathy. We've had patients from other ethnicities that have a GNE myopathy, but unless you're thinking about it, you're not going to be able to figure it out. And then in some places, especially with the smaller insurances, we may not be able to get genetic testing. They may not approve it. There's a lot of reluctance on the insurances to pay for these genetic testing. And their rationale most of the time is that it's not going to change management, therefore we should not be able to pay for it as well. So the multidisciplinary clinic in neuromuscular disorders is not a new model. It was established in the 1950s by the Muscular Dystrophy Association, and they used Jerry Lewis, as some of you may be aware, as the spokesperson for these clinics. That's why anyone going to those clinics were known as Jerry's kids, because these were mainly children with muscular dystrophy, and Jerry was a big champion of that. But it's a model that's very well established, and every clinic does it slightly differently. The pediatric model may be slightly different from the adult model. So in a pediatric model, they get seen by multiple MDs on the same day, which is neurologists, pediatricians, cardiologists, orthopedic surgeons. In most adult clinics, they usually get seen by a neurologist and maybe one more MD. But most of the work is done by the ancillary therapist, especially physical therapy, occupational therapy, and speech therapy. And it's a very valuable model because above and beyond seeing the neurologist, there is an added benefit to seeing a therapist to go over your physical therapy evaluation, to assess your disability, assess the need for adaptive devices, etc. On that. In addition, we have social workers, we have genetic counselors in the clinic, and we also, for some of the clinics, also have a nutritionist, which allows for a much more comprehensive, holistic approach to a patient care. So if they, in certain diseases, they have failure to thrive, they're not able to put on weight, and you can have a dietitian go in and intervene. If there are family members who have issues regarding childbearing or with family planning, you can have genetic counselors go in and talk to the patients. If they are having issues with breathing difficulty, the respiratory therapist can measure their lung capacity, etc. This model has been adopted by other disease models. So ALS, which is Lou Gehrig's disease, again, very successfully runs these clinics. At our site, we worked with the Myasthenia Gravis Foundation of California, which is a local foundation, and we have a twice-a-month myasthenia clinic. And then cystic fibrosis, which is a rare but lethal disease of the lung, also has this model. And they've actually done a great job of creating a registry. They actually have very good data from their clinics, and that data was used for some of the newer treatment trials, as well as bringing new treatments to fruition. So cystic fibrosis is actually the model that a lot of the folks in the field are trying to emulate. So at our center, right now we have the Muscular Dystrophy Association clinics, which have been in existence since I started here in 2000. And within those muscular dystrophy clinics, most of them are general, so that's where we see most the other patients. But then we have thematic days. So we do a late onset Pompe disease, which is another ultra rare myopathy. We do it in collaboration with genetics and with support from the industry. So it's funded by the Sanofi Genzyme group. And then we do a myositis clinic with rheumatology. So we play along with other specialties, and that's been in existence since 2014. We have support from both the Muscular Dystrophy Association as well as the ALS Association to run a multidisciplinary ALS clinic every week. So we see a large number of patients through that. And as I mentioned, we have twice a month myasthenia gravis clinic. And all of these clinics are staffed by neurologists. So in addition to me or Dr. Goyal or some of my colleagues, we have the trainee physicians who are the fellows. And in addition, we have a physical therapist, a speech therapist, and a respiratory therapist in these clinics. So this is the comprehensive list of all the team members that are part of this clinic system. Now, not everyone, especially amongst the therapists, are going to be there every clinic. But in general, you have the neurologist, the physical therapist, the speech therapist, the respiratory therapist in every single clinic. And all of this is quarterbacked by our excellent nurse coordinator, Melanie Mayton, who really does the yeoman's job of making sure that the patients get seen by all the team members, follow up in terms of post-clinic plans, etc. She's in charge of that. And on particular days, for instance, when we have the MDA clinic, MDA will send one of their health services coordinator. ALS Association has a former nurse who's the case coordinator. She comes into the clinic in person as well. Both of them are staying home right now because of the COVID pandemic, but typically they would be there in the clinic. And then we right now don't have a full-time social worker, so we are borrowing somebody from the other clinics. And in addition, we have designated subspecialists. So for instance, we have a designated pulmonologist, we have a designated surgeon, we have a designated cardiologist or a geneticist who is able to see the patients within a day or two's notice if the need should arise. We try not to bring them into the clinic because then that would make for a very long visit. But other than that, we can usually have them see the patient right away on that. So these traditionally have been in-person visits. Patients come in, they usually spend anywhere from 1 to 3 hours to see all of these people. They get seen by the physical therapist, they get very helpful advice, they get screened for clinical trials, etc. Now, since the COVID epidemic has happened, there have been significant changes to this clinic, and that actually gives us an opportunity, and that's one of the reasons why Lale and I and Nancy have been thinking about this more. So the clinic visits now pretty much have switched to video visits during the COVID. So during that period between March 15th through May 15th, and nobody was being seen in person unless they had an acute emergency. Most of the visits were being done over video visits. The hospitals and clinics, even though they had resisted going to TeleVideo and they kept telling us how long it's going to take and it's going to take us 2 or 3 years, literally overnight switched to video visits. It was amazing. When there's a will, there's a way. And they somehow figured out how to do this. In our institution, they literally did it in a 4-day period on that. In Medicare and the insurance has also allowed these visits to be considered as equivalent to an in-person visit. So the reimbursement for the physicians, for the hospital, was the same if you were doing a video visit versus an in-person visit. The telephone visits were initially also reimbursed at the same rate, although they quickly realized that they're not the same. So the reimbursement for that has been reduced. And there is a place for telephone visit, which is mainly for doing medication checkups and maybe giving laboratory results and a quick follow-up. So we still do a fair number of a fair number of telephone visits, but bulk of the visits right now are video visits. The other thing that happened was that these federal rules regarding patient confidentiality and protection of your health records were relaxed. So this is the HIPAA rule, which is in place in the US, and they were significantly relaxed. So now we could use a variety of video platforms to make these video calls. So a lot of the healthcare systems in the medical records had built-in Zoom. So we can use Zoom, which is a platform to call the patient and see them. But you could use FaceTime, you can do WhatsApp, you can do Blue Jeans or Skype. And then there's an app for physicians called Doximity, which has a video built into it. And I can call a patient directly on Doximity to do a video visit. Now, these are currently because the rules are relaxed. Once the rules go back into effect, it may or may not be possible to do that. But right now, there is a great opportunity to do that. The other rule that was relaxed was that previously we were not allowed to see patients from outside California. So right now, because of the COVID pandemic, that rule has been suspended. So we can, sitting in California, I can see a patient in New York, I can see a patient in New Hampshire, I can see a patient in that. Our compliance folks still are not comfortable with us seeing the international patients, but at least in the US, we may be able to do that. And that's something that that's part of the bureaucracy we're dealing with right now, that we're trying to sort out some of these legal issues more than anything else. And then one of the challenges with virtual visits is that you're not physically in the room. So anything that requires a hands-on experience is difficult, but we've learned quickly how to do a decent neurological examination over the video, and actually it's getting pretty good at that. The other advantage of a telephone visit or televideo visit is that we are now able to observe you in your home setting. How do you get out of your chair? How do you get out of your furniture? How's your furniture placed? What other structures are there that may be impairing your ability to safely walk inside the house? What equipment do you have at home? Do you have rugs, carpets, etc.? So our physical therapist, for instance, is loving it because he actually gets to do what's an equivalent of a home visit to look at all of these scenarios at this point. As a patient, you don't have to get up at 7 in the morning, face the traffic to come see me an hour away because you don't have to travel anymore to see the doctor. You can be sitting in your home and you could be doing that. And that's been, again, a major advantage for some of the more disabled patients who don't have to worry about arranging a caregiver, asking somebody to drive them, etc. And then the visits actually go faster. So as opposed to an in-person visit, which is taking up a patient room, and you have to wait for the patient to vacate that room before you put in the next patient, in virtual visits, they are all virtual rooms. And you can create as many virtual rooms as you want. So you don't have to wait for the next patient to get room, because you can have multiple rooms going at the same time. So the visits actually don't take 3 hours anymore. The visits are now taking maybe an hour, hour and a half at best. That. You can have multiple providers. So if I need the physical therapist, I can just ask him to jump on the call and help me advise the patient, or I can ask the speech therapist to jump on the call and that. And right now, as I mentioned, insurance companies consider these visits to be the same as an in-person visit. On that. There are disadvantages. Your examination is limited. I cannot listen to your lungs. I cannot listen to your heart. I cannot look inside your mouth very clearly. I cannot, if you have a bump or a lump, I cannot palpate it. I cannot really measure your muscle strength other than just seeing if you're grossly moving your hands up and down or not. And then for research purposes, where we really would like to create a repository of very valuable biological specimens, whether it's blood, whether it's urine, whether it's saliva samples, so we can do future studies on it. We obviously cannot obtain that over the phone or over the video. And then from my research interest point of view, where we would like to look at natural history study, we would like to create new outcome measures that would be successfully able to measure the disease. Obviously, you cannot do that as well over the video visits. Since May 11th, there has been a general relaxation of patient visits. So now we are starting to go back to, most of our clinics are up at about 100 to 125% of functional. So the clinic volumes have been restored. Most of the visits are still virtual. So I would say in our clinic, about 70 to 80% of it is virtual visits through over the video. The new patients can be seen virtually, but we prefer to see them in person. And now we are able to resume doing EMG nerve conduction studies, which are the electrical testing that cannot be done virtually. We can draw the bloods, we can do outcome measures. One function that has been restricted is the pulmonary function test. Our clinic was able to do your lung function test bedside. The challenge with that is that it generates aerosol, and if the patient has a COVID infection, that will contaminate the room and put everyone at risk. So right now, we are not doing pulmonary function testing on everyone. The select patients that we absolutely need to do the testing, we usually have them come in a day or two earlier to get tested for COVID first, and then decide whether, and then do the testing once we figure out they're COVID negative on that. Even in the long run, once we get over this pandemic, and God knows when that's going to happen, because at least the numbers in California seem to be creeping up, the expectation is in the long run, even after everything gets restored, insurances and Medicare will allow roughly about 30 to 40% of our patients to continue to do virtual visits for follow-up purposes. And in a model where we need to see you maybe once in 6 months and once a year, which most of our patients are, you can do alternating video visits with an in-person visit. So maybe once in 6 months, we check on them over the video, and then the next visit, which is another 6 months away, they can come in person. So they only have to come in person one out of the 2 visits. Yeah. What we are proposing for the GNE Myopathy Clinic is a patient that will come in, will be seen by the neurologist for all sorts of assessment. These could be new patients who have never been diagnosed. These are patients who have a family member affected and they want to be checked for possible carrier state. These are patients who have symptoms, but we don't know if they carry the gene mutation or not. And part of the reason would be to confirm the diagnosis, provide genetic counseling, sorry, and to assess their disability. Now, during these visits, we will also have them see by the physical therapist. For the GNE Myopathy Clinic, because the upper extremities are often also affected, we will also have the occupational therapist being there. And then we usually have a respiratory therapist present. So if the patient has any respiratory complaints, we check it. But in general, I'm a big fan of checking respiratory functions, even in patients who don't have symptoms, because we have found out that they may be silent or asymptomatic respiratory involvement. And since the mobility is decreased, the patients don't complain of shortness of breath on exertion as much. So knowing their respiratory status at least once a year would be a good idea. We will have a genetic counselor available for questions, really, especially related to new diseases, new diagnoses, but also in terms of marriage planning, in terms of offspring planning, etc. And then the social worker can help with disability paperwork, with questions related to lifestyle and job placement, etc. on that. And then we can have other therapists such as speech and nutrition available for questions on that. Now, to me, the biggest attraction, in addition to taking care of the patients, there are the outcome measures that we can measure. So, and this would be an opportunity for us to do muscle dynamometry, which we don't routinely do in a clinical situation. But since these are research outcomes, we can measure them, and that doesn't take more than 5 minutes, and it doesn't require any needles. We can do 6-minute walk test. We can do test get up and go, and these are done by trained certified therapists. So we know that the quality of the data is good. A lot of our therapists were trained by Ultragenics and trained by Genzyme for high quality data collection. We can also do stair climbing. And then this will give us an opportunity to either create new outcome measures or validate some of the outcome measures such as GNM, FAS, which was designed by Ultragenics for their trial. And then this is an opportunity for us to create a biological repository of samples, such as saliva, blood, skin biopsy, etc., for future use on that. And then for future diagnostic and research purposes. Obviously, at this point, and just to answer the question that was asked about COVID, the visit is going to be voluntarily. We would prefer, again, my personal preference for the new patient would be to come in person, but we can definitely do it over televideo, especially given the concerns about the coronavirus. But once the coronavirus settles down, and if distances are not an issue, then we would like it to be an in-person visit as much as possible on that. What we are proposing is eventually creation of GNE myopathy comprehensive clinics in various parts of the US. We think it should be strategically located on the 2 coasts to capture most of the patients, and then also 1 or 2 sites in the middle of the country to attract patients from the other parts of the states in there. And then similar setup can be done for Canada, for Europe, etc. On that. The option is for inpatient visit, which, as I said, for new patient is preferred, but we will have the mechanism for virtual video visits as well. It will allow us the ability to do long-term data tracking and collection of biospecimens and outcome measures. It allows us an opportunity to attract industry-sponsored, because for them to have so many patients in the same room or same clinic is very attractive. And we've seen that with Pompe disease, we've seen that with myasthenia, we've seen that with ALS. So it will allow us to get sponsorship for them to develop some of these outcome measures, develop new clinical trials. But I think another important thing, and as I'm not getting any younger, and a lot of the folks who deal with GNE myopathy are not getting any younger, we need to train our next generation of neurologists, physiatrists, or geneticists to recognize this disease and provide a good, solid advice rather than speculating based on their experience from these clinics on that. For the time being, once this goes through the bureaucracy of UCI, which being a state institution can sometimes take a little bit of a time, UCI will be the pilot site, not the exclusive or only site. I want to be very clear. We're not trying to monopolize this. This is because we have done this, and we want to test it out here first, see what the problems are, what the issues are. We are proposing an initial frequency of every other month clinic, so 6 times a year for 1 half day on a Friday morning. It'll be a maximum of 6 patients in a clinic. And the patients' visits will be covered by NDF, and which surprisingly has created more bureaucracy for me, but I think it's a good idea, because the advantage of that would be then we don't have to worry about whether the patient has insurance or not, or whether the patient has the right insurance or not. And unfortunately in California, where we have a lot of capitated managed groups, I want this to be egalitarian rather than exclusive on that. So NDF has agreed to pay for 1 neurology evaluation and 1 physical therapy evaluation for each patient once a year, which I think is a great and very laudable idea. And then if this model comes out to be successful after a 1-year pilot, we will definitely create similar clinics in other regions of the country, and maybe work with local associations to generate clinics in other parts of the world as well. So at this point, I'm gonna stop talking and I'm gonna play this video from Carol, who unfortunately our timings didn't match, so she couldn't be here, but she was very kind to record this video. And so I'll see if I can play this without any technical glitch. And then I am available for any questions or comments on that. All right, here we go.
Hi, everybody. My name is Carol Gelbard. I'm a licensed therapist, and I want to talk to you a little bit about the emotional wellness program. This is being pre-recorded because unfortunately I was not able to be there today, but I'm excited to have this opportunity to work closely with Dr. Mozaffar and the multidisciplinary treatment team to discuss patient needs and figure out how we can provide more supportive care services to them. So I want to talk a little bit about the emotional wellness program, but before I do that, I wanted to share with you, those who are not familiar with me, a little bit about my background. I have been involved with the Neuromuscular Disease Foundation for many years. I served on their board for 8 years, and I also was involved in hosting the first patient day in 2015 in New York City. And the goal of that first patient day was really to get patients more involved to become self-advocates. And I'm going to use that word advocates throughout this discussion. So that leads me to talk about how we really first started to get patients to be advocates and understanding the disease from an educational standpoint. And through these patient symposiums and through my work of being a facilitator in the patient groups as well as the caregiver groups, I have come to a better understanding of what are the current stressors and the needs of people that have GNE myopathy. And that was a big part of why we wanted to launch this program. So let me talk a little bit about emotional wellness and what exactly that is. Emotional wellness is really focusing on one's ability to understand, share, and manage their feelings. It's often affected by how we cope with life's challenges, how we deal with the stress, can often have a direct effect on our health. So we want to have patients find the necessary ways to manage the stressors that come along with having a chronic progressive disease such as GNE myopathy. A lot of thought went into why we are using the word emotional wellness. We really wanted to come from a strength-based perspective and really work with patients on what are their current strengths, how can we capitalize on that to help them cope most effectively with this progressive disease and all the challenges associated with it. We really wanted to empower patients to address their emotional wellness as well as their physical wellness. We really wanted to take the stigma out of needing a mental health service because it's understandable that patients who have a progressive disease would have some feelings and responses associated with it. And we wanted to make sure that we address that as well and come from a place of it is understandable that you would have these challenges. And we ultimately want to help patients cope more effectively to manage one's emotional as well as physical health. Now, let me tell you a little bit about what my role would be as a consultant to NDF. I will be doing a needs assessment, which basically would be 1 to 2 sessions with patients and hopefully later on caregivers to really determine where are people at, what are they having trouble with, how can we help them find what kind of supportive services that we can suggest and offer to them to help them cope more effectively with the disease. And it kind of serves as like a kind of a check-in, like where are you at, what's going on, what can we do to support you? So what are our goals in launching this program? Ultimately, we want patients to empower patients to implement self-care plans. And not everybody's care plan will look the same. We really have to look at what resonates with each patient, what things seem to work for them, what things don't work as well, and kind of customize what would make the most sense given where they're at. And then we want them to adopt more adaptive coping skills. And we can talk more about that as well in the sessions. And we want them to access interpersonal support that can look different for every patient. Some patients want the peer-to-peer support. Some want to go on the Facebook page and reach out to others. Some will look at other avenues and how to get interpersonal support. We also really want to emphasize how therapy and counseling could be useful and really talk to patients on how to find the necessary services in their area and what to look for when trying to find a therapist who might meet their needs. The other goal would be to help establish supportive care services, and we can talk more about that. And that would be related to what you heard from Dr. Mozaffar with his team of us working together to really think about what could we do to help this patient at this time, and what kind of services can we provide. And it really has become clear that from talking to patients over the years, they really want to be connected to professionals and experts that know a little bit more about GNE myopathy and understand all the challenges and stressors associated with this disease, so they can get the proper care that they deserve. So that is a big part of why we're launching this program, because there was definitely a need for more specialists that are familiar with GNE myopathy. Because it's a rare disease, it's often hard to find. I'll give you an update on where we are on the program's launch. So we're in the beginning stages of this. So we have been working with Dr. Mozaffar and with his team, as well as with Nancy, Lolly, and Rachel, about what would be useful, creating needs assessments, a form that would target the areas that seem to be significant and helping identify needs, the current needs of GNE myopathy patients. We're going to set up a online scheduling website that patients can book directly sessions with me, and there would be we're going to also we worked really closely on the messaging that helps describe the program. During the pandemic, I actually facilitated an NDF patient huddle, which I was really able to get to meet some of the certified patient advocates and get a sense of what some of the current issues. The huddle was really about self-care and managing anxiety during the pandemic. And then it was put into a podcast, and I was pleased that a patient had reached out to me that hasn't really been that connected with NDF to request a session on how he can cope more effectively with what's going on. And what I thought was great about that is that we're accessing people that maybe wouldn't have gone to the symposiums and the huddles, but want a more private consultation with someone that could really kind of help determine what would be useful. So in this launch, we sent out emails to all our certified patient advocates to give them opportunities to set up sessions with me to talk about their emotional wellness. And also we want to get a better understanding of the social and emotional needs of GNE myopathy patients, develop more opportunities for peer-to-peer support. Another thing that I feel has come up repeatedly is when I've talked to patients is they really want to get connected to somebody that is in a similar stage of life as they might be, as well as someone who might be in a similar stage of the disease progression, because that seems to be comforting to patients, to talk to someone that understands what they're going through and help them navigate a little bit about some of the challenges that they're currently having, some of the fears that they might be having, and all of that. So I really want to help with our certified patient advocates in developing, getting to know each of them so we can kind of link the newly identified patients or newly identified patients to NDF to link them together to provide this peer-to-peer support, because I have found from talking to patients that's been incredibly valuable. I am in the process of scheduling sessions with this certified patient advocates. We have a few of those scheduled over the next couple of weeks. And ideally, I wanted to be there today to talk about this, but I will do another presentation in the fall that will go into more detail about emotional wellness, and we'll talk about tools that people can use for self-care and adaptive coping. And that will happen in the fall. And the NDF website will be updated soon, and it will have articles about self-care and support, and articles that support emotional wellness, as well as giving people steps on how they can get in touch with me to set up a session to do a needs assessment. My email is below. So if anybody wants to reach out to me, they can contact me at cgelbard@lcsw@curehibm.org. And feel free, since I wasn't able to present live and field questions, to contact me or let the NDF team know if there's anything that we can do to be supportive. And thanks again for listening, and wishing you all well. Thanks. Bye-bye.
All right. So again, the intent is to create a clinic where we can provide a holistic approach to GNE patients. We are proposing visits once a year, which could be in person or virtual. These opportunities, there's currently an opportunity, given the relaxation of the HIPAA rules and some of the insurance rules, to be able to see patients from all over the US. We still do not completely understand the realities of seeing patients from abroad or outside the US, but we are working on trying to discover more. And these multidisciplinary visits will provide a unique opportunity not only to take good care of the patients, but also to develop very important natural history and longitudinal data and disease scores, collect valuable biological specimens, and create a repository and interact with industry partners to create research trials and studies in GNE myopathy. So I'm happy to answer any questions, take any comments.
Thank you. Thank you for that presentation. We are so excited at the potential to launch this program. I know that most of our speaker series events have been based on our scientific research, and this is something that we're doing or hoping to do concurrently with all of that to help current patients as much as we can, given that you are our mission. So hopefully we're going to be able to get this off the ground. I think it's an ambitious program, and I think that with Tahseen's guidance and leadership, hopefully we're going to be able to get it going. I'm going to ask the questions that are here in the chat, and I thank everyone for those. If you have any further questions, go ahead and put them in there now. I did want to just quickly touch on what Carol was saying and make sure that you all understand that visits with Carol, virtual visits with Carol, will be separate from the clinic. You'll be able to book those in addition to appointments at UC Irvine, and those will be starting soon, so feel free to reach out to her. One person who already had the opportunity to meet with Carol, I just wanted to read something that this person sent me. This patient told me that Carol is brilliant. I've never really had any form of counseling like this, so it was really valued. She was able to understand me and help me support myself better. Thank you so much for giving me that space to be open and honest. So I hope that in addition to the medical attention that we're hoping to be able to give you, that this emotional wellness component is something that you take advantage of and that you find additive and helpful to you. So with that, I'm going to, Tahseen, go to some of these questions. Mangesh asked, is there any possibility with the appropriate patient consents for the Ultragenics natural history study to be combined with or donated to the NIH natural history study?
So I may not be fully in the loop on that. I know that the Board of Trustees here at NDF is working very hard on it. Ralph Lauren, who's our board member as well as a lawyer, for the NDF has been in discussions with them. So the plan is either for NDF to take over that data, or for them to give it to the companies or NIH that's working on it. There's been an ongoing debate and discussion about it.
Yes, we're very hopeful that that information will become available. Mona asks if there are any figures regarding patients with respiratory weakness following pulmonary tests from natural history studies, given, specifically given concerning, the concerns pertinent to patients with regard to the COVID-19 virus.
So again, COVID-19 is very new, so we don't have any information related to that. But the general idea is that if patients who are significantly weak, especially to the point of needing a wheelchair to walk, probably should get the breathing testing done, even if they don't have symptoms, because the diaphragm, which is your main breathing muscle, is after all a muscle. So if the rest of the muscles in the body are not functioning, there may be some involvement of the diaphragm. And that becomes important because if the diaphragm is involved, then you have to take better care in terms of management. So I'm a big fan of routinely checking pulmonary function, even if there are no symptoms, because you can find a lot of asymptomatic or pre-symptomatic involvement, where the patient may not have symptoms, but they clearly have involvement. And when I say management, these things are manageable by positive pressure ventilation. So BiPAP can really fix the problem, because you can overcome the respiratory insufficiency to a great extent. Flu vaccine every year is going to be something that's going to be important. Proper pulmonary hygiene is going to be important. So I really think it should be done on a routine basis. And to answer your other question, Mona, I'm not sure that we have much data on facial weakness. But again, these are the kind of questions that we would be asking once we start doing a longitudinal study. And I'll give you an example: the inclusion body myositis, which is the sporadic disease that a lot of these clinics, a lot of these patients get. We never appreciated the facial weakness in that disease till recently. Now it turns out that about 50% of those patients have quite significant facial weakness. Same thing with respiratory insufficiency. So when we did our large cross-sectional evaluation of patients with inclusion body myositis, a number of them had quite low forced vital capacity or lung capacity, which was never appreciated before. So I think the more you look for these things, the more we know about this. But right now, we don't have enough information. And same thing with swallowing and other things as well. So yeah, I think you're hitting all the right points. That again emphasizes the need for why we need to do this on a systematic fashion.
Okay, thank you. I'm just trying to get through these. It looks to me like you may have addressed Tara's question, but I don't know if everyone can see the chat. She asked, since there are many MDA clinics in the US, are we able to piggyback on their locations so more patients will be able to be seen in GNEM clinics? And I think that kind of piggybacks with Mangesh's question. Do the multidisciplinary clinics at different sites, such as UCI, Stanford, et cetera, collaborate with each other on other ultra rare diseases that can be used as a model for GNEM as well?
So my understanding is there are close to 300 MDA clinics across the country. Now, some are very small, some are very large. Not every one of them have the same expertise, so each clinic has its own strengths and weaknesses on that. And so the larger ones for sure are, and again, especially in areas where we tend to focus. So for instance, our focus is Pompe disease and our focus is GNE myopathy. We know all the other MDA clinics that do that, and we collaborate with them on a regular basis. In general, MDA clinics are collaborative efforts. We have a yearly meeting of all the MDA clinics, both regionally as well as nationally, so we get to meet with them. So yes, I mean, again, in areas where you don't have a GNE myopathy clinic, it's important for you to establish yourself with a local MDA clinic. But one of the concerns is that even in the MDA clinics, they may not have experience with GNE myopathy. And that's why having an option for a virtual visit is something that we're interested in. So in addition to keeping your regular clinic, you can then still work with a clinic that has a lot more experience with GNE.
Right. Okay.
There was Nancy, there was a similar question about international and Canadian clinics.
Right.
So in the UK, there is a muscular dystrophy campaign that has these regional centers of excellence that see all the neuromuscular patients. So for instance, Newcastle has one, Oxford has one, London has one. In Canada, some of the big sites like Toronto and Vancouver have very established clinics. But I don't know the Canadian system at all. And then there are similar setups in Europe. I mean, Europe tends to be more universal health. They are government-based facilities. So a lot of the patients get referred to specialized centers in Europe, which is a good model, which probably will never happen in the US, but something to look into. So in general, I think the care for patients with neuromuscular disease may be slightly better in these European countries than in the UK, in the US right now.
Well, we're going to work on that, right? Tammy has a specific question, and I can refer her maybe to you later on after the call, but she has a 16-year-old son who was diagnosed at 13, and she's looking to get him evaluated by you or someone who's participating in our clinics, and she's in New Jersey, so maybe we can offline give her some suggestions about how she can go about doing that.
Yeah, I mean, so Children's Hospital of Philadelphia is an excellent hospital, and they have great pediatric neurologists, but they also have a excellent geneticist out there by the name of Livia, who's really, really good. But the nearest GNE site, if I were to recommend anyone, would be Dr. Heather Lau at NYU in Manhattan, who has a lot of experience with GNE. She's very, very good. And she herself is a pediatric neurologist, but also a geneticist.
Okay, so Tammy, we'll make sure we get that information to you. And then the last question here sort of goes back to the COVID-19. Mangesh is just asking if there's any guidance from U.S. multidisciplinary clinics that work on neuromuscular diseases about whether patients are considered higher risk for more severe effects.
It's the routine precautions that apply. So patients above the age of 65, patients who have pre-existing conditions such as diabetes, or other immune conditions are at risk. And if they have respiratory involvement, then they was obviously going to be at risk.
Okay. All right, I think that you have addressed everyone's questions, Dr. Mozaffar. So thank you so much for giving us your time. I know that you are incredibly busy and started your day at 4 a.m. local time. So I appreciate your taking the time and meeting with us and announcing this exciting development and program that we're really hoping to launch as soon as we can get through the red tape and all of the things that we need to do with regard to compliance. We have to make sure, obviously, that this is all done right. And we will definitely keep everyone posted via our website and social media and our emails as we develop the program. In the meantime, the emotional wellness component is available and going strong. So I want to also let everyone know that next week we will be back with another speaker series event with Dr. Monko Lek and Catherine Kazwara from the Lek Lab at Yale. They will be speaking about research. They're going to give a research update on collected GNEM patient samples, which I know a lot of you are very interested in hearing about. The recording of this event and all of our other previous speaker series events are available on our website, curehibm.org. We'll be back to our regular time next week, 12 noon Pacific, and registration is open and available for that event. So in the meantime, I just want to thank you all for joining us, for giving us your time, for continuing to support our efforts, and we're here if anybody needs us. Thank you, and I hope you all enjoy your weekend. Thanks, Tahseen, so much.